So with this framework in mind, here is a synopsis of our approach. We developed an overall project charter. To educate our leadership on the Flow Along project, we went to several hospital committees to inform them of the flow spread strategy, to engage their support and approval for what was coming. The task force that formulated this overall charter continued to stand and grow with the addition of one new process owner each time spread continued. This allowed process owners to learn from the current members about the challenges, opportunities, and to idea share. Our teams typically consisted of a process owner, a CCAC discharge planner case manager, a charge nurse or coordinator, and other healthcare professionals. Physiotherapy was a consistent allied health presence in the rural hospital communities and the implementations that occurred there. But prior to implementing any Flow Along plan, separate charters were produced that reflected the local challenges and their opportunities. We were fortunate that the groundwork for measurement had already been set with the original Flo Collaborative, so the measurement piece was copied and applied to all spread sites. And it was the practice in the original Flo Collaborative to use a monthly leadership report. This remained a vital part of the Flow Along communication strategy to allow progress to be monitored by all stakeholders. So how will we know we're making that a change is an improvement? This is a shortened list of the measures we used to determine whether our actions were making a difference. We used a mix of process, outcome, and balancing measures. What changes can we make that will result in improvement? We had essentially answered this question in the original Flo Collaborative. Now we had to test and modify the tools and evidence to suit their new contexts. These tools included bullet rounds, whiteboards in both the nursing station and in the patient room, stoplight color, visual indicators, and a long-term care DVD we produced with a frequently asked questions section. The team felt it was critical to build and maintain the continuous improvement culture necessary for sustained improvement. And our education efforts included the model for improvement, PDSA and small tests of change, and Lean. At all times, the process of quality improvement was highlighted, not just the tools or the outcome measures. Meaford Hospital had implemented bullet rounds all the way back in June of 2008. And here we see the overall effect it has on the average length of stay for all discharged destinations combined, from 7.5 days down to 6.1 days. That's a sustained 19% decrease. This graph shows a change from 2.96 bed turns to 3.69, a 25% sustained increase. Now, Meaford was also able to sustain a decrease in average length of stay for the ALC patients as well. This graph shows a previous state of 30.7 days with a decrease down to 16.3 days after bullet rounds were implemented. That's a 47% decrease. But it's important to remember that the different pressures exist in every different context, and all of our sites and in our units are different, so comparison is tricky. So here's some bullets on lessons learned. Without a plan or an aim, you do not have a process that is clear to follow. Leadership support is critical in giving backbone and purpose to your projects. And we all talk about patient-centered care. We have to keep reminding ourselves that a process improvement that doesn't benefit the patient will be challenging to hardwire into the culture and contributes to the overall waste. To implement a process change without the input of those who will be using it is like inviting the Canadian Olympic hockey team to arrive without their sticks. Great uniforms and skating skills, but no chance of scoring goals. Maybe that's what happened the other night. All staff are looking for ways to make things better. They just need to know that their ideas are being heard and can be acted upon. So data to start is important, data to throughout and data to finish. It will show you if you're changing for the better. Are we staying the same? What can we do to make a difference? Data can show the way to direct your team's efforts. And we always identify communication as important, and it really is. It needs to be planned and executed. Remember to celebrate your successes. and bringing food is always welcome. Efforts that don't work or show the improvement that you want are just another way for your team to learn. It is the power behind plan, do, study, act. And the only thing in life that never changes is change. Now a few words on sustainability. Change is sustained by many important factors: leadership, engaged staff, and a continuous culture, to name a few. But I want to leave you with a few of the projects we have continued to do on the original Flo units. Bullet rounds have continued on the original Flo Unit 4.1 and are hardwired into the way we do things. But a recent team survey revealed suggestions that could improve nursing report content and time spent on each patient, and a renaming of bullet rounds to discharge rounds. We are making a great thing even better. We continue to require the role clarification in the different team members that participate in at discharge rounds. I can't say bullet rounds anymore. We do not want any gaps in identifying the patient's required discharge requirements. In order for Flo not to appear as a one-off experiment, the continuous improvement in culture is being sustained by the recent deployment of lean initiatives to improve the work environment and staff satisfaction. 6 S projects have reduced inventory waste, time looking for stuff, and staff stress. In Meaford, change continues in the form of adding nursing report to discharge rounds and some recent lean initiatives. And I will now let Elaine, the program director of Meaford Hospital, say some closing remarks on this and some next steps.
I don't think I would be overstating it to say that the original Flo Collaborative has been one of the farthest reaching process changes in my time at Grey Bruce Health Services. We have adopted the model for improvement as our project management methodology, and we've incorporated this into a brand new project charter that each process improvement group has to formulate. We are developing a group of staff with expertise in key project processes and methodology. We now have a middle management portfolio for patient flow. This expertise has led us to our placement on several LIN committees and task forces. Our current and our next work: we have developed a falls prevention program that works along the same line and used the same methodology that we used for Flo, that was done in collaboration with CCAC, and looks at the patient from the community through the ED into an inpatient care and back into the community. We've done pre-surgical screening Flo in Owen Sounds to see how we can reduce barriers to putting patients through pre-surgical screening, and we've done the same thing in the Meaford OR with the surgical daycare process. We've also streamlined the morgue process, which may sound a little bit strange, but we had different processes in each of our sites and different documentation and different rules and regulations about who could be there. So we were able to use the same methodology for improvement to standardize the process. The criteria is still the same. We used, we are electronic documentation in all of the rural sites, and we are electronic documentation in all the ORs, in all of the sites, and all of the emergencies in all of the sites. And so using the Flo process of looking for wastage and looking for things that could be improved in roadblocks, we developed electronic documentation and audit processes for all of those electronic documentation software. We're doing ongoing restraint education by looking at what was the problem, how did it have to be changed, and using the Flo process as well. We're also looking at learning management. How can we make it easier for our staff, who we've all said a number of times are very busy in whatever department you're in, not just nursing, and how do we make it easier for them to learn? And we've developed a computerized, or instituted a computerized learning management system that can be accessed from home. On a final note, please read and reflect on these words. Thank you.